Hello, this is Dr. Quinn for Medic Mentor. So this is the medical stream for the study guide for the February 2019 issue. So it's great that you can join us tonight, and by all means you can watch this video at any point. My colleagues Sharon and Sherry-Ann have both delivered their veterinary and dental presentations yesterday, so you can access them on the Medic Mentor channel right now. So I watched them and learned a thing or two yesterday as well. So I would strongly encourage you to have a look at those streams. The podcast, this webinar tonight, is going to focus on purely the medical stream. So the medical PBL, we're going to go through the SJT case, go through the critical appraisal as well, and then go through the debate on alcohol and problem drinking in the UK. So let's get started. So the problem-based learning case. So you may have all had a chance to have a look at that. Problem-based learning is a very commonly used approach in all medical schools and all professional courses, health professional courses now. And it's a very good way of learning because it takes a very broad story or case and then allows you to explore what interests you. And often at medical school, you will work as a group on those PBL cases, and then you'll teach each other what you've learned after your workings on it. So it's great to get into the habit of getting used to PBL and working through it, right away. So in this case, we were describing a young woman who's pregnant and who's unfortunately developed a significant infection during pregnancy, which did have sort of long-term complications. So I do have some slides to share with you. Now, I have managed to figure this out, which I know we've had problems with before. So just bear with me one moment. I just want to try this. So what I figured I'm going to have to do is share each page of the slide as I go along. So it might take a little bit of time, but not to worry. Okay, so we've got the questions here. Now then, let's go back. Okay. So the first question was about routine pregnancy screening. Now, so in the UK, all women can expect to receive routine antenatal care. That means care during the pregnancy period. Now, even before antenatal care, there's a lot of preparation and work to be done, and it's recommended that all women thinking about pregnancy, they're advised to manage things like diet, stop smoking, ensure that they take folic acid supplements even before they try to conceive, and this all aims to optimize the pregnancy. Now, the antenatal care period lasts all the way through from conception up until birth. So you can see here in this diagram, so we all know that a typical pregnancy period duration is for 9 months. Now, that period is split up into 3 separate trimesters. The first trimester is the period of the most sort of organ development, fetal development, is all focused in really a 12 to 13 week period when all the key architecture, the key fetal structure is all laid down. Then when you start to move into the second and the third trimesters towards the end of pregnancy, the focus in those periods of times is on essentially growth and development more than anything. It's really just the fetus growing in size principally. And there's a little bit of organ development beyond what's already been established in the first trimester. Now, what this means is the first trimester is the most risky period for pregnancy. So if there is a particular insult to the fetus during that first trimester, the first 12 weeks or so, then there is a risk that it could result in an abortion, a spontaneous abortion in utero. And also that's when, because the organs are laid down in those first few weeks, then that is when babies are most at risk of congenital malformations developing in that early window of time. So that's why it's always better to aim to plan a pregnancy, because then to be avoiding things like alcohol, smoking during that first window of time. So in the UK, the first time, once a woman knows that she is pregnant and she's confirmed it, then she'll have a booking visit. And this is when basically she's given all the advice she needs during the pregnancy period about what to expect, about what scans she's going to need. And there's also a few other components to that visit. So let me just bring up those slides for you. Okay. Here we go. Okay, here we go. Right, so what you can see here is that in the booking visit, so the women will have a blood test taken. This is really important to establish first their blood group, which I'm sure you've been learning about in your A-levels. So that's whether they're blood group A, B, or O, essentially. And if they're A, it all depends on the antigen, the specific markers on the red blood cells, and therefore, depending on what blood group they are, they will display the opposite antibody. So people in blood group A have the A antigen on their red blood cells and therefore have B blood group antibodies. So if you were to give a person with A blood group B blood, they would get a massive hemolytic reaction, and it would be very significant and cause them risk of death because of a transfusion reaction. So that's one important thing. The other factor is the rhesus status, rhesus D, whether they're positive or negative. This depends on partly the status of it's essentially so, for example, a woman who hasn't had a previous pregnancy may well be rhesus negative because they've not had previous exposure to the rhesus protein. So it's therefore important to screen for it. And if women are rhesus negative, then they will need anti-D prophylaxis later on in pregnancy to prevent, again, another reaction occurring. Because when women are sensitized the first time to rhesus D, it's when they have a second period of exposure that they're much more at risk. And it's not just risk for them, it's more risk to the baby. So rhesus D group is particularly important in pregnancy. The other things we look for are hemoglobinopathy status, so whether women have sickle cell or thalassemia blood types, whether there's any element of anemia, whether they need iron supplementation, and then if it's important to consider if they've had any previous blood transfusions and whether they have any red cell autoantibodies, alloantibodies, sorry. So those are two of the things. The other factor is looking at infections. Now, the key infections we look at are syphilis, HIV, and hepatitis B. So HIV and Hep B are your viruses. We used to screen for rubella, but don't routinely do that anymore. And there's other infections that we don't routinely screen for. We would only consider them in women who are particularly at risk. A good example of that is hepatitis C, for example, very commonly transmitted from IV drug use. So therefore, if you've got a women with risk factors, then you may start taking those into account and screening for them as well. It's important in any woman to record her height, weight, and her BMI. Because that will help women who are significantly overweight or obese, that itself is a risk factor for pregnancy. So it's important to consider this and make sure you're monitoring patients down the line. In terms of the social side of things, you need to make sure the woman has good support system at home, and unfortunately not all women will. You need to consider who else is at home. Are there other children at home? Is there a partner at home? And who is that woman's essential support system? You need to think about the woman's occupation and high risk occupations as well. And if they are drug using or anything like that, because all of those things do form risk to both the mom and to the developing baby. They might sound like awful things to be talking about, but you do see them, and it's particularly the vulnerable women, and teenage pregnancies that are the women going through pregnancy that do need that little bit extra support and assistance. Now, the other fact I've mentioned here is about Down syndrome. Now, Down syndrome should be offered to all women. Now, we know that Down syndrome, women of older years, so moving sort of, well, it's basically the relationship is increasing depending on what age, but older women do have a higher risk of having a baby with Down syndrome. However, in terms of absolute numbers, it's actually younger women who proportionally have more children with Down syndrome. Just give me one moment and I'll be back with you in a second. Okay, so in terms of Down syndrome, so as I said, all women should be offered Down syndrome screening. And the tests that I've described here depend on the period through the pregnancy. So the combined test is the first test that can be provided in the early stages. So usually about at the booking visit, 11 to 14 weeks typically, you can do a blood test and do the nuchal translucency test. Now this is basically when you're doing an ultrasonography of the baby, so like your baby scan, you can measure the amount of fluid, the width at the neck of the baby, and this is there's very complex embryological reasoning behind it. But if that NT length is outside of normal range, then there is a risk that the baby could have Down syndrome. It's not diagnostic. You would advise the woman to then go on and have a more diagnostic test, such as chorionic villus sampling or amniocentesis. But it is a good indicator that there is some sort of fetal anomaly. Now, the triple and the quadruple screening tests are other tests that can be offered later down the line. Quadruple testing, for example, happens usually at about 20 weeks during the pregnancy. And it's basically 4 blood tests that are measured. So AFP, beta HCG, estriol, and inhibin A are the 4. And again, depending on the which of those are increase and decrease will give you a good idea whether that baby does have Down syndrome or not. And all women who are considered to have a high risk of a Down syndrome pregnancy based on their screening test are offered an abortion, typically in the UK, and then it's up to the woman whether she decides to take it or not. Okay, so that's your booking visit. So I realize there's a lot of information there, but as a medical student, I sat in many obstetrics clinics and I saw women, being screened, having all of these tests done, and really making sure you're giving the woman the best chance of having a successful pregnancy and a successful outcome. Now, women, depending on whether they are nulliparous, so what that means is not having had a previous pregnancy, will determine how many visits they have. So if they haven't had a pregnancy before, they will have more appointments. If they've had a previous pregnancy, they will have fewer appointments. Now, in terms of the ongoing visits women have, they will be screened for bacteria in their urine. This is really important because women can be asymptomatic, so they have no signs or symptoms of a urinary tract infection. But if they do have bacteria in their urine, they are at high risk of it ascending up to the kidneys, causing an infection called pyelonephritis. And this can be very severe. A woman can present with fever, rigors, vomiting, back pain, and can develop sepsis, and it can be overwhelming. So in this case, you always screen for it, and you would always treat it with antibiotics if you identified it. You should also be monitoring blood pressure all the way through the pregnancy. Now, obviously, some women will be hypertensive before they are even pregnant, which is another issue. But what we really worry about is new pregnancy-induced hypertension, because this could be a sign of preeclampsia. Now, preeclampsia, again, it's a complicated pathophysiology, but essentially it's poor integration of the placenta to the fetus. There's a lack of blood supply, and therefore the woman tends to develop hypertension. Now, preeclampsia may or may not be symptomatic. It tends to affect women towards the third trimester, and the only treatment for preeclampsia, if it's a preeclamptic crisis, is delivery of the baby. So in that case, you may have to do a C-section, cesarean section. But typically, if women, do have signs of hypertension, it needs to be controlled, because you need to maximize that blood supply to the fetus, because that's what determines how healthy they are, their nutrition and their growth and development. So you would control blood pressure in pregnancy quite aggressively. Usually you can use IV infusions or tablet medication. Quite commonly labetalol is used. So that's preeclampsia, a very severe pregnancy-specific disease state. Gestational diabetes, also unfortunately more and more common, and gestational diabetes refers to diabetes that arises solely in pregnancy. Now, a lot of women who develop gestational diabetes will go on to have either long-term type 2 diabetes even after pregnancy, or they are at increased risk of developing type 2 diabetes at a later date. So it is a significant entity, gestational diabetes is. It should be measured, usually it's about the 24 to 28 week period that you test. You usually can test the urine, you can do an oral glucose tolerance test, which is the best diagnosis for diabetes. But if you do suspect it, then it does need treatment and management. So typically with diet, and they often use metformin as well in gestational diabetes. So it's very important and something to be aware of, because women who do develop gestational diabetes, there are inherent risks to the baby, risk of a bigger baby, that then even has long-standing risks all through life. It's sort of Becker's phenomenon that babies of obese diabetic mothers have increased risk of things like vessel disease in the future, high blood pressure, heart disease. So it's very significant. Now, symphysiofundal height is essentially the measurement of the tummy, and it should only really be done from 24 weeks, because that's when the baby is really of a significant size to measure, and it's a good indicator of how well the baby is growing. If a baby isn't growing very well, there's lots of reasons for that. It could be partly perhaps malnutrition from the mother, but it could also be because of a lack of blood supply, a poor placenta, sort of interaction with the fetus. The vasculature isn't as good as it should be, and then there's external factors that affect fetal growth, things like smoking as well. There is a big risk of intrauterine growth restriction with drug and smoking abuse. So it's very important, and actually babies are more at risk of intrauterine growth restriction if they're from mums of poorer sort of socioeconomic families and status. So it's something to get on top of very early. In terms of position of the baby, so this is when we talk a little bit about labour later on, but when you're thinking about how the baby's positioned in the tummy, if its head is in the right place to come out for delivery, and if not, thinking about doing a procedure called an ECV procedure to try and resurrect that and get the baby in the right place, because of the risk of a breech delivery. So basically the baby its head not coming out first and not coming out in the right sequence, perhaps its shoulder coming out first, it coming out foot first. There's all different combinations, and that is a significant risk to the mum and to the baby, and the baby especially, because the baby's head essentially needs to come out first to allow it to take that first gasp of air, to allow it to then proceed through the delivery process. So if it comes out foot first, then you've got a significant problem. So checking position is important. And then finally, we talked about the term of labour, which is usually about 3 months. Now, when there are certain disease groups, for example, patients with diabetes, where you don't want to leave the labour too long, the pregnancy too long, because the baby's getting bigger in that time. It's going to get harder and harder to allow for a normal vaginal delivery, and therefore, particularly if it is a big baby, that is sometimes an indication for doing a cesarean section. But regardless of disease state, for all women, once they get into about 41 weeks, then you want to try and be inducing this labour. And the first mechanism is usually a membrane sweep, which is essentially placing a gloved finger into the cervix, and then trying to induce the pregnancy that way. But then you've also got tablet or medication induction of labour, or mechanical induction of labour. Of which I won't go into tonight, but essentially you need to get that baby out. It can't stay in the womb forever. It's getting bigger. The pelvis is only so big and will only allow a certain size of baby to pass through. So that's, I realise that's a lot of detail, but that's your summary of your antenatal care in the UK for women having a routine pregnancy. And that's important to note, because women who have other premorbid conditions, so things like diabetes, or thyroid disease, or I'm trying to think what else, asthma is another one. These are women who need more attention, and you may also need obstetrician-led care rather than midwife-led care. Now, the majority of routine antenatal care is led by midwives in the community. The midwife will come out to the home, and then they may occasionally need to come into clinics, but it's service provision is important, and it's all about determining the risk of the pregnancy, and that is done right at the start at the booking visit, essentially, to decide what care that lady needs. Now, I'd also talked a little bit about geriatric pregnancies, and my slide included a picture of Meghan Markle, because technically she is classed as a geriatric pregnancy. Now, geriatric means the elderly, and geriatrics is care of the elderly, a specialty in medicine. Now, a geriatric pregnancy is anything usually above 35 years of age in the female. Now, that might sound awful calling that geriatric, but actually what we've seen in modern times is women are having babies and pregnancy much later in life. And actually the window of opportunity for fertility really is up to about 30. So anything from 18 to 30 is the best window of time. It's when women are most fertile, and the risks of pregnancy are less. So as you go anything above 30, the risks are increasing. But particularly above 35 years and above 40 years, there is a very significant increased risk. I've listed some of the problems here. You've got sort of a sudden intrauterine death, so death of the baby in the womb. You've got preeclampsia increases, which we talked about earlier. Gestational diabetes also increases. Preterm birth, so that's your premature babies, babies are usually viable from about 24 weeks is the standard we use in the UK. Some research studies have managed to make births prior to that viable, but the risks are very significant, and the survival rate is very poor. So we usually say about 24 weeks in the UK. Which is a very, very early baby, and preterm births is high risk with older pregnancies. Then you've also got risk of neonatal deaths. So neonates is basically the babies when they're first born. In that period of time, it's usually from what I can recall, it's usually about, I think it's about 30 weeks or 3 months or so. It's really the very first few weeks of life. And then I've already talked about Down syndrome. Now, the next question, so let me just bring up the slide, because I have a little bit I wanted you to do in this section. So let me just bring up for you. Here we go. So this is some surface anatomy for you. So thyroid, the thyroid gland. So if you put your neck up and you feel down from your chin, feel very slowly, you can feel a prominence. That's your laryngeal prominence. So the larynx is basically the voice box of the trachea, above the trachea. It contains the essentially your valves that allow you to speak, and the muscles that allow you to do that. Now, below that, if you look at the diagram, you can see you've got some of the cartilages and the ligaments, and then you've got the thyroid gland in the neck. Now, the thyroid gland is basically like your basal metabolic regulator. It controls digestion, controls your gut, the rate of processing, controls your energy levels, your tiredness. So many things are controlled by your thyroid, and your thyroid is under the control of your hypothalamus in your brain, and the hypothalamus controls the pituitary, which controls the thyroid. So if you have like a negative feedback system, which I'm sure you may have learned about in your A levels, so the pituitary gland, essentially, let me bring up this slide for you, make it a little bit easier then if I show it. 1 second. Got my it's like the pituitary gland is called the endocrine orchestra, and endocrinology is certainly my interest, and that's because it essentially controls the negative feedback loop for the entirety of the body. Now, if you can see here, you've got your hypothalamus, which releases thyrotropin releasing hormone, which acts on the pituitary gland, releasing the TSH, thyroid stimulating hormone. So it does exactly what it says on the tin. It acts on the thyroid gland to induce release of its hormones, its messengers, essentially. So that's your T4 and T3 hormones. Now, the main hormone we tend to focus on in clinical practice is T4. T3 tends to be for more academic purposes, really. So once your body releases these thyroid hormones and they start working on their second messenger systems, all around the body, then the levels in the blood will build up, and then that will feed back to the pituitary gland to tell the pituitary gland to stop producing TSH, because essentially we've got enough thyroid hormone. Then the thyroid hormone levels reduce, and then it goes back and forth in a negative feedback loop. It's negative feedback because as the thyroid levels build up in the blood, it has a negative effect on their production because they're not needed anymore. There are examples of positive feedback loops as well, and oxytocin is a good example in pregnancy, but most endocrine feedback loops are negative feedback. Now, that's not to say it's an on and off mechanism, and actually you will be producing thyroid hormone pretty much all the time. It's a very, very sensitive system, a bit more complicated than this demonstrates, but it's nice to think of this in a simple way. Now, the next question, moving on from thyroid disease, was about gravida and para. Now, essentially, gravida is the number of pregnancies that woman has had. Now, pregnancies will include a lot of things. It will include babies that have gone to term, so 37 weeks to 42 weeks, classed as term. Preterm deliveries will also be included, but also abortions and miscarriages will be included in all of that as well. It's about the number of pregnancies that woman has had, regardless of whether they've been successful or not. Now, the para is how many actual deliveries they've had. So whether, they may have had 4 pregnancies but only 1 delivery if they sadly had 3 previous miscarriages, for example, or 3 previous abortions, or whatever it might be. So that is a system we use, a national system in obstetrics and gynecology, to get an idea of the woman's obstetric status, essentially. Okay, now the next question, and what the focus of this case was all about, was about toxoplasmosis infection. Now, so I had quite a nice picture of the life cycle here, which basically it shows that from cat litter, from rats, you get the cats lay the fecal oocytes, which are ingested by the rats, and then also ingested by livestock like pigs and sheep. And then if the humans eat undercooked food that isn't properly cooked, that still harbors these oocytes, then they are at risk of developing toxoplasmosis infection. Now, other risk factors for toxoplasmosis are dealing with cat litter as well as another factor. And we talk a little bit about primary prevention of toxoplasmosis later, so don't worry about that. Now, I've got another slide I want to share with you, so let me just show this to you. Here we go. Right, so this slide shows the Canadian guidelines for management of toxoplasmosis, and there were quite a few questions in the medical stream based on this. Now, the first thing is, as I told you earlier about all the routine infections that we test for in pregnancy. And you may have noticed that toxoplasmosis was not a routine infection. And that's because actually, you would pick up a lot of false positives if you did it like that, and potentially false negatives, and it just wouldn't be appropriate. So really what is appropriate is if you consider a pregnant woman to have had exposure to toxoplasmosis, only then, and if they typically become unwell with symptoms of fever, headache, joint aches and pains, then you would want to explore further. Now, the best investigations to do is called serological testing. So you take a blood sample and measure the levels of antibodies, so IgM and IgG. Now, classically, IgM is an acute antibody we produce. IgG is more a long-standing infection antibody. But actually, in toxoplasmosis, that is not strictly or entirely true, and both IgM and IgG antibodies can be elevated. One may be elevated and not the other, and therefore when you are actually testing for these antibodies, you need to be very careful about their interpretation. And that's why any samples testing for toxoplasmosis should be sent to a reference laboratory rather than be done at the hospital's own pathology lab or microbiology lab, for example. So that's very important to say. Now, with toxoplasmosis, the mother might well be infected, but that doesn't necessarily mean the fetus is infected. And that would certainly be a good thing. Obviously, there's an element, there will be a bit of a lag period, and if there is maternal infection, there is risk of transmission via the placenta to the fetus, but it doesn't always happen, and it's not guaranteed. And it's actually more likely to happen in the first trimester, in the earlier stages of pregnancy, than it is in the later stages of pregnancy. However, this lady had exposure quite, sort of later on in pregnancy, which decreased her risk of transmission. However, in this case, both her antibodies came back positive, and therefore, under the advice of a specialist obstetrician who was an expert in toxoplasmosis infection, she was advised to take a macrolide antibiotic. So in this case, it was spiromycin. This was because fetal infection had not been confirmed. Now, in women who have maternal infection, they should go on to be investigated for fetal infection as well. And the best way to do this is via amniocentesis testing. So this is where you take a sample of the amniotic fluid. It's quite a big needle, and then you send that sample off for testing to determine for PCR, polymerase chain reaction analysis. So essentially looking at the DNA, the RNA, the viral structure of the genetic material, essentially, and then to determine if there is evidence of toxoplasmosis infection in the amniotic fluid. And if there is, then it's the baby is certainly affected. And therefore, if that was confirmed, then you would change your treatment strategy slightly and change the antibiotics that you give to benefit the fetus and the mum. Now, I've listed that here. I wouldn't worry too much about the specifics. This wasn't something that I knew. It's something I had to look up at the guideline. But that is the sort of combination of therapy a woman should receive. Now, the final point is about whether women are immunocompetent or immunocompromised. Now, pregnancy is a state state of immunocompromise relative to a non-pregnant woman, essentially. Basically, your immune system takes a bit of a hit because your body is focusing on far more important things like a developing fetus. So women are more at risk of infections during pregnancy. But the majority of women will be immunocompetent, won't have any problems, and therefore they don't need any prophylactic treatment. It would just be, if they do develop toxoplasmosis, it would be treated. However, if women are immunocompromised for any reason, so very common reasons in pregnancy for immunocompromise would be things like HIV. In more general medicine, we talk about more patients who are receiving chemotherapy or cancers, for example, or more your immunocompromised population. Then you always need to be more careful, because this population are more at risk of developing infection in the first place, and when they do develop infection, it's much more likely to be severe, much more likely to be sepsis, much more likely to be overwhelming, with much higher mortality, and therefore it's never to be underestimated. Okay, so I've got, let me just show you, I've got you some pictures, because I also talked about the risks of toxoplasmosis, because it's not just about being infected, it's also about what it actually does to the developing fetus, because there's not really any effect on the woman, it's more the developing baby. So this is a slide, this is a Google slide basically, that I've presented, and you can see this baby. So what you can probably see is a bit abnormal. It has a very, very big brain, a very big head essentially, which is essentially hydrocephalus, which is swelling of the cavity. Now you can also have macrocephaly, which is where the brain doesn't develop normally, so they have a very small brain and head, and both are very, very significant congenital malformations. Other features are chorioretinitis, which is basically inflammation of the choroid and the retina, or in the back of the eye essentially. So I've got a nice picture to show you of the back of the eye. So let me just show you that. One moment. Now, this is what I say, a nice picture. It's not a very nice picture at all, really. But it shows to you quite nicely what it can actually look like if and it explains why this child later in life did have some eyesight problems, and chorioretinitis can lead to blindness, and it doesn't always cause ocular abnormality from the time of birth. There is a key window when sort of your vision develops, and it's usually within the first year of life that you're laying down that architecture, neuronal architecture in the brain. But actually, children who have had a congenital toxoplasmosis infection, so by congenital we mean infection during the in utero period, the fetal development period, they can develop ocular problems all the way up until about 5 years of age. If they get to 5 years and haven't had any problems, that they're not really going to have anything. But they can become blind up until that age, and it's usually the macula that is affected, as you can see here, a very significant inflammatory process of the choroid and the retina at the back of the eye. So very, very, very significant malformations is what we're talking about. Now, in terms of primary prevention of toxoplasmosis, so things like washing hands before and after handling food, washing all fruits and vegetables, and everything you eat, ready prepared salad and things like that, making sure you wash them thoroughly, cooking raw meats thoroughly. Women aren't advised to eat any raw meats or unpasteurized cheeses, sorry. So women do have to be particularly careful in their diet during pregnancy. When handling soil or gardening or dealing with cat litter, again, you have to be extra careful. Women in pregnancy are advised to wear gloves more than usual, and it's simply because of the congenital risks to the developing baby. Now, the next slide I have for you is about the labour process. That was the next question. Now, the delivery process is very complicated, and it's something that gives medical students a great deal of horror to learn this for their medical exams, as you can probably see why. Now, there are 3 stages of labour, which haven't put here. But the first stage is essentially sort of the head is starting to engage, the cervix is starting to dilate. Once it dilates by 10 centimeters, it's considered to be at full engagement. Now, that period is when the woman is also getting contractions, and we measure cervical dilatation all through the period, because if the quicker the rate at which the cervix dilates, the quicker the pregnancy is going to be, essentially. So that is the first stage. And so the first stage of labour ends once the cervix is fully dilated. The second stage of labour is actually going from the delivery process, so all the way from baby in womb to baby delivered, essentially. And then the third stage of labour is when the woman delivers the placenta. That's the third and final part of pregnancy. It's an important part of pregnancy, when you need to cut the cord as well. It's very important that you remove that placenta, because essentially it's full of vessels, it's full of vasculature. And if women can have retained products in the womb, which can continue to bleed, continue to cause problems, so it's very important that they pass that placenta. And if they don't, then they might need to go into theatre to manually extract the placenta, essentially. So that is the third and final part of labour. Now, you can see the stages here. Now, the first stage is sort of before your engagement. So that's baby in womb, happy, and not quite ready for delivery yet. Now, the next stage is when the head is starting to engage just above the cervix. You can see here it's starting to flex its head a little bit to get into that initial position needed to be delivered. And it's starting to descend down. You can see it's because of the engagement of the head. Now, the next stage is, again, the descent is the start. You've got these contractions to push the baby further down and out. And you can see the head is starting to rotate as well. And then moving on to complete rotation, internal rotation initially is what the baby will do. And it's all because of if you think, and you can't really picture it unless you have an example, a baby, a model, but the precise proportions of the head are very closely sized to the pelvis. There's not a lot of room for maneuver, and therefore getting into the right position is critical to allow for a successful labour. And if you have a pause in these points in time, that it can cause significant brain damage and brain injury and hemorrhage and hypoxic injury to the baby. So it's critical that this process happens exactly as it says here. And if you identify at any point that this labour is not proceeding in the way it should be, then you may need to introduce instrumental delivery, so ventouse or forceps, which you may have heard, because you need to get that baby out, you need to get it breathing, and you don't want to be putting it at any unnecessary risk. So once you've moved, if we were looking at D, weren't we, complete rotation, and then the baby starts to extend its neck, okay, because it's got to get its head out first. That's the first thing. It's got to take that first breath of air, which its first sort of pulmonary circulation, which it doesn't have in utero. And then you've got complete extension of the head, then really stretching to make sure it can get out head first. Then you've got the restitution. So that's where the baby's starting to come back to how it was in the womb, essentially. And then anterior shoulder is the first, then I say the first, the second part of the baby that should be delivered, anterior shoulder. And as babies get bigger and bigger, this process becomes harder and harder, because women's hips aren't getting any bigger, but babies are, and they are at risk of, for example, shoulder dystocia, where the shoulders just don't come out, and you can end up causing significant injury to the baby if they get stuck, essentially. So more and more we need to be picking up on big babies, we need to be picking up on women who aren't going to be able to deliver, and then perhaps consider for example, cesarean section, so basically tear to get the baby out through the abdomen. You've got your anterior shoulder, then your posterior shoulder is delivered, and then the rest is pretty straightforward after that. Once you've got the head and the shoulders out, it kind of all goes well from there. So that's it. You can see how complicated this is, and I certainly had to relook at this and just remind myself, because it was something I knew as a medical student very well, but you forget the details over time, but it's very important. Now, the final question on the PBL was about epidurals and Entonox. Now, Entonox, the first thing was simply gas and air, essentially. I'm sure you've all seen it on Holby City or Casualty, women breathing in this gas, which makes them feel wonderful for all of a few seconds and then wears off very quickly. That's the downside of gas and air. It kind of makes women feel very sick as well. They often feel very nauseous with gas and air, but it's very safe. There's no real risks, so it's still very commonly used in pregnancy, in labor, essentially. Now, the other thing form of anesthesia I wanted to talk to you about was epidurals. Now, epidural, let me get the diagram up for you. It'll be a lot easier to explain for you then. So one moment, let me just bring this up for you. Here we go. Okay, so you can see here in this diagram, you can see the bony vertebrae, and then within you've got the spinal canal, which sits the spinal cord. The spinal cord is extension of the brain, which allows there's nerves that come out at every level, every vertebral level, essentially, which are providing your lower motor neuron, movement, sensation, etc., for your arms, your chest and your lower limbs. So you can see here you've got your spinal cord, which is your important part, but surrounding that is your epidural space, and this is sort of your fatty tissue that surrounds the spinal cord. Now, this sort of is for protective purposes, but we actually find it very effective to use to introduce anaesthetic into this epidural area. Now, the big benefits of this are you've lost your pain receptors in your womb to some extent. You can get a bit of weakness in your lower limbs, sensory disturbance, numbness and tingling in your lower limbs. But principally, it's an analgesic. Is its principal aim in pregnancy. However, obviously you're introducing a needle, as you can see, quite closely to the spinal cord. So there are very rare but very significant risks you need to advise the patient about. So a risk of permanent spinal damage if you go too far in. That really should never happen, but you should be counselling patients that it is a risk. There's risk with any procedure, invasive procedure. There's a risk of hematoma and a risk of infection, and you have to counsel all patients about that. And then other risks are things like it can sometimes slow down the pregnancy a bit. If you have a bit too much anaesthetic in the epidural, then women won't be able to walk around. And then other things like, the epidural, they have to be attached to the anaesthetic machine. So again, another factor that decreases mobility. So it does slightly increase the risk of needing instrumental delivery. So like I spoke about, ventouse, essentially suction and forceps delivery. But it's not, it's epidural is used by lots of women these days. And actually, the risks are very low of anything I've talked about. And actually it's a very effective analgesic. So, which is why it's so commonly used. We don't really use the spinal anesthesia, so actually anesthetic into the CSF surrounding the spinal cord. That's more a surgical practice if needing perhaps C-section, for example. So that, let me just check. I think that completes everything I wanted to do about the problem-based learning case. Now, I'm a little bit conscious of time, so I'm going to very briefly go over the SJT and the debate, and I just wanted to touch on the critical appraisal as well. Now, I'm going to talk about the debate first, and it was about units of alcohol. So let me bring up this diagram for you. Okay, so this diagram shows you all the units of alcohol, and this is what we should be recommending to patients. And it's actually often a lot less than what patients think it is. And that's important to say. Obviously, it depends on the concentration of alcohol. That's an important factor. Depends on the glass, because glasses all vary. Fortunately, in restaurants and bars and eating outlets where they serve alcohol, they have very set measures now, and they're very strict about that. But this is what you should be counseling patients about, what a unit of alcohol looks like. Now, we have a system in medicine where they've looked at blood ethanol levels following alcohol consumption, and then it very tightly links to the symptoms that patient will experience. So very low levels, you get those initial feelings. I'm sure most of us have had, if we've had alcohol before, a sense of warmth and well-being, and then moving on to euphoria, your judgment goes down from what you would normally do. And then as you start to get into more significant levels, ethanol levels in the blood, then you start to get your incoordination, less reaction time, your reflexes go off a bit. And then really when you're moving into quite severe levels, that's when your cerebellum fails you, so you don't have any balance, your speech is slurred, your eyes are all over the place, you have double vision. And then ethanol can cause coma and even respiratory depression and even death in grossly excessive levels of ethanol or alcohol in the blood. So that's how we do take ethanol levels in clinical practice. The other day I saw a patient with an ethanol level that should have meant he was dead, but obviously it was a much more chronic alcoholic who was up and about and looking not too bad. So it does show you about ethanol tolerance depending on how much you drink, which is quite scary. But essentially, there are 3 different levels of drinking alcohol. There's sort of very low risk drinking, the odd one here and there, which is what when I ask most patients, that's what most patients tell me they do. There's then moving on to hazardous drinking, where the alcohol is not actually causing any problems, any physical problems or social problems, but there is a risk that it could start to be doing those things if they continue to consume or consume any more. Once you move on from hazardous, you then move on to harmful drinking. This is where alcohol is actually affecting your function, your social life, your well-being, your physical health. So it's actually having determinable effects. And then at the very end of the scale is your dependent drinking, your people who get the shakes, confusion, hallucinations, even seizures if they don't drink alcohol. And it's very scary to see, and it's representing a very significant level of alcohol abuse over usually a very prolonged period of time. Now, there's multiple long-term effects of alcohol. So on, all different things linked to cancers, linked to heart disease, linked to liver disease critically, and cirrhosis, scarring of the liver and liver cancers. Pancreatitis, alcohol is a very common cause of pancreatitis, essentially inflammation of the pancreas, which is a very severe condition. So all round affects every organ system, every body part, and can lead to a lot of brain damage and vascular disease and in the brain, and sort of shrinking on the brain as well. You see a lot with chronic alcoholism. So it is very, very significant. And then, aside from the physical problems, alcohol makes you more likely to commit violent crimes, and crime in itself, and more likely to, be a domestic abuser as well. Alcohol contributes to all of these things. So a very significant social burden with alcohol. Now, when I told you about that man who came in with a very significant ethanol level, so what would we do for him is essentially measure his level of withdrawal, whether he is withdrawing or whether he's acutely intoxicated. But once they start to withdraw, then we measure their symptoms. So factors like agitation, hallucinations, orientation, sweating, and tremor. And then on a scale, and then determine how much essentially benzodiazepines they need. So that basically to limit the effects of withdrawal, essentially. Now I'm going to turn my slides off because that completes my little bit about pregnancy from the PBR case and about alcohol. Now, I wanted to very briefly go over the SGT with you, and then finally we'll go on to the critical appraisal. So with the SJT case, you're essentially a young doctor, very keen on research. You've left out some papers about patients who can be involved in research trials. And with the research trials, this patient has expressed a concern that his data isn't going to be held confidentially. It's going to be seen all over the world, and he's worried that he's going to be identified. Now, as with any SJT case, situational judgment test question, the first thing to do, you need to try and correct the situation by yourself within the limits of your capability. So the first most appropriate thing to do here would be to ask the patient what his concern is, because perhaps he's had a case where a family member's had their information divulged or whatever, and you need to reassure him that that is against protocol and policy, and will not happen, and it should never happen that we divulge information inappropriately. So the first thing, ascertain the patient's concerns. Let me just double check the questions. I just want to make sure I'm getting it all right for you. That was the first most appropriate thing. The second most appropriate thing, so to just explain to the patient that the informed consent has to be obtained from everyone, and that it can be taken out of the study. That's very important. If patients are good enough to give up their time to be part of a study, you have to counsel them that they can come out of the study at any point with no effect on their healthcare or future healthcare, essentially. That's a very important message to communicate, because sometimes patients sign up to studies and then don't actually have the time to be able to commit to them. So that is how I would counsel a patient moving forward. The next thing then, how can you resolve that situation for other patients? And that would be producing leaflets that make sure you're clear about, consent and how their information is kept confidential, and how that is maintained through all research practices. So that would be a solution to the problem. Now, the next things that aren't appropriate here would be to ask the senior nurse to go and talk to the patient. Now, nurses, you do have research nurses who are involved in the consent process and confidential handling of information in research studies, but actually it's not really the responsibility of the nurse in this case. It would be unfair to ask her to do it when you, as the doctor, could quite capably do that yourself. And then the least most appropriate thing would be just to brush it off. I think we're starting, if you've been through these webinars as we've gone along, you'll see a consistent theme that if you brush anything off or you say, oh, it's all okay, the simplest option is usually the worst option. Not always, but that's a theme I think we've seen in the last few weeks, that you can't just brush it off. You need to acknowledge a patient's concerns, ideas, and expectations, and make sure that you address all of them, because that's how you ensure that clear communication and make sure the patient is satisfied with the care, and that's how you build that patient doctor rapport and trust that is so important in our practice. So that's a situational judgment test. And then the final thing was about this article that we will go through. So probably about 10 minutes we'll spend on this now, and then we'll draw to a close. So I don't know how many of you were able to actually access the article, but it was a little bit of a joke article for those of you who did manage to access it. And I would be really pleased if you accessed your own articles as well. Essentially, this article was about whether using the word quiet at the start of a night shift actually affected the number of referrals that were made to that service during the on-call period. So they had for example, they had two control groups, randomized controlled trial. The first group, the registrar would say, have a quiet night to the team who were on that service for T&O, trauma and orthopedics. The control group, the registrar at the start of the shift would say, have a good night. So quiet didn't come into it. And so they measured the number of referrals over a long period of time. They had about 20 night shifts in each group, roughly. And then what they showed was that saying the word quiet, have a quiet night, did increase the number of referrals in the intervention group compared to the control group, which had fewer referrals. Now, it's very interesting. You could certainly, is there any scientific feasibility behind that? But actually, the way the study was done, it had quite a few strengths in our critical appraisal process. And although it was a slightly ludicrous study, it just showed that you can do a ludicrous study in a very good way. So what I'm going to focus on is all of these questions that I've presented in the study guide. I just want to give them a bit more detail because I know that all of you will be having to critically appraise articles for your A-levels, particularly if you're doing science A-levels. I know I had to do it for my biology, my chemistry. So you will need this as a skill. It's a very important skill. Critical appraisal is a skill you will use all the way through as a medical student and as a doctor. You know, all the time we are obliged to keep up to date with the evidence base. We're obliged to be reading papers in our fields and to make sure we are enabling best practice for our patients and we are acting safely and according to literature. So it's a very important skill. Now, I want to take it from the beginning. Now, in any paper that you read, the first thing you'll see is the title, and then you'll see the list of authors. Now, usually as a general rule, if you only have a couple of authors, it's usually a smaller scale study. It might be a narrative study, it might be an opinion piece. If there's a big group of people, then it's probably more likely to have had sort of international collaborations, perhaps, multi-centered approach. Not always, but usually, and it's good to see where those authors have come from. Are they from different institutions? Has there been a good amount of collaboration? Other things you'll see straight away are where the study's been published. Is it a reputable journal? What is its index? How highly ranked is that journal? Things like Lancet and the BMJ are effectively our gold standard in the UK. If you can get a paper in there, that's usually the best. Now, I'm saying that, but remember there is a certain element of almost editor's preference for some articles, and some articles will get into the BMJ, some won't. And I think as long as it's gone into a reasonable journal, but even sort of perhaps non-reputed journals, it could still be a good article. It's for you to appraise it. So don't base it all on the journal it's been published in. The other thing you'll see right at the start is the year it was published. Now, don't rule out science that was published in the 1990s, for example. I know that seems like a really long time ago for the new generation. And yes, okay, it doesn't have the scientific rigor, it doesn't have the standards by which we publish in these current days. But it could still be a landmark paper. There are landmark papers from that period that still affect and influence our clinical practice today. So don't let the year put you off. It is sometimes reasonable, depending on what you're investigating, to have a year limit. So, for example, if there was a new technology that you're looking at that only came out in 2004, perhaps it would be reasonable just to allow your search criteria from 2004 until present day. But if you're going to set a date criteria, you need to have a good reason why. Okay. Now, conflicts of interest is another important factor. Now, in a lot of the big randomized controlled trials that you will come across, a lot of the authors, the clinicians' names in there may well have conflicts of interest. So they may well have received travel expenses or sit on professional advisory boards for those big pharma companies. And, I think they're important to take into account. Um, but actually, what I've found in my own work on appraisal is most big academics, big researchers do have liaisons with big pharma, with professional companies. It doesn't mean, that they're biased. It doesn't. It just that's big pharma is a way of driving research, and we wouldn't have nearly the number of randomized controlled trials that we do have if it wasn't for big pharma and the big pharma industries. So I think it's important to take it into account when you're reading anything, and just be thinking about it. Is this actually affecting the results, or the results independent of this? Do they make sense despite these conflicts of interest? Okay, so then you've got the abstract. The abstract is the first thing you'll come across. It's usually 300, so 250 to 500 words, depending on the journal, which usually has a brief introduction, a couple of lines, methodology, a couple of lines, the results section, of which results will be portrayed depending on what's appropriate, and then the discussion section or conclusion. Now, it's a very small piece of text. It's very important to get it right. The most important things in an abstract really are the key methods, what was strong about the methods. They're not going to talk about their weaknesses in an abstract. The results need to be clearly displayed. You need to display the key results to the paper. You're not going to present all of them by any means. It's the most significant findings that need to be portrayed in the abstract. And then the discussion is very important to get right, because it's the concluding factors, it's the message that those results tell you about that topic area. Now, abstracts can be very well written, but I've seen a lot of very badly written abstracts as well. And there is a bit of an art to it, to writing concisely the key messages in 500 words. So it's certainly something that takes a lot of practice, is what I would say. So the abstract is the first thing you will see. Now, then when you go into the body of the paper, if you can get access to the paper, there are some papers you can't get access to. You would need a university login or whatnot to get access. But if you're looking at the body of the paper, the first thing is the introduction. Now, remember, the introduction is very subjective for the piece. It's been written by the authors based on what their agenda is, based on what they think you need to get out of the results. It's from their perspective. So actually, the introduction shouldn't really tell you anything new as such. It's just sort of leading you. It's leading you through the paper. So I know an academic who always used to tell me that never read the introduction first, because that's your story. Read that at the end and keep it objective. So it's your choice. And then you've got the methodology is the next bit. So this, what sort of study was it? Was it a randomized controlled trial? Did they have blinding if it was randomized controlled trial? Was it an observational study? Were they looking over a period of time at patients and following them up, like a cohort study, for example? Was it a non-randomized clinical trial? So did they have two groups, but there wasn't a rigorous randomization process in place? Was it right at the top of the tree? Was it a systematic review? Were they just collating all of the evidence together and assessing what's already out there, to looking at what is positive, what is negative in the data, in the literature field, and then putting it all together to decide if overall there is a positive association or correlation? So method is important. Have they been clear about it? Do you have any questions about the methodology? If they've said it's blinded, have they told you how it was blinded? And you would be surprised the number of papers that do not go into detail on their methodology. The methodology should be such that if you wanted to redo that study from scratch, you could do it without problem. That's how detailed the methodology should be in reality, because that is what science is about, isn't it? It's about reliability. It's about if you do something, your colleague should be able to repeat it and get exactly the same results. Otherwise, how do you know what is right and what is wrong? So methodology and detail is very important. Also about the statistics. Statistics are very complicated. I'm not, I have done more statistics than most medical students, and still it's a bit of a minefield. Ideally, you will come across very common statistically used tests. And then what I normally do, especially if I don't know what the statistic is that they've mentioned in the paper, I'll put it into Google, I'll find out what the aim of that statistical test is, and then I will compare it to their aim, their study aim, and their question. And does that statistical test meet the question that they're trying to answer? You would be surprised the number of papers that actually have a big mismatch, and it's usually because of lack of knowledge with statistics and because of a professional statistician has not been involved in the process of writing up the paper or working through the results. So that's an important one to make sure you get right. What population did they study? Was it a very niche? How many people were in the paper and in the study? The more people, the more likely it is to be accurate. If you've only got 10 people, is that truly representative? If you imagine, if you're doing a study in your school and you took 10 people, you took a class, that is by no means representative of the entire school. So the more people, how well powered is it? Do you have enough people to be able to determine the hypothesis that you're trying to determine, whether it's right or wrong? So population is very important. The best populations usually come from international studies, so multiple centers across the world, because then you're like trying and testing your hypothesis in multiple areas, multiple regions. So it's much more likely that the results you do find are applicable and reliable. So that's your methodology. Then you move on to your results. Now, results will be displayed in a paragraph format, but should also be displayed in usually a tabular format for the baseline characteristics. So if you do have two separate groups, are they the same? If you've got a randomized controlled trial with a control group and an intervention group, and right from the start, your intervention group are younger, they are non-smokers, they are fitter, more active, lower weight, compared to control group. I can't remember what I said, intervention group or whatever, compared to the other group that are completely the opposite of that. How can you aren't comparing like with like, are you? If you give an intervention to one or not the other, it could be all of those factors that are leading to an effect rather than the actual intervention. You want to, in science, we want to eliminate the factors that could be causing a difference. So therefore, you need your two groups to be the same right from the start. And that's very important. If you have a randomized process, they will be different. They won't be the same. If it's not randomized, you're at risk of there being differences between the two groups, essentially. Okay, so that's your randomization. That's your baseline characteristics section. You then move on to your formal results. So usually presented, as I said, in a paragraph and also in graphical formats. Do the graphs you see make sense? Does the figure make sense with the graph? Does the text tie in with the graph? Are they the same, for example? And that's I like to look at both. I must admit, I like to look at graphs first and then go to the paragraph results section. And they should have listed all of their results, negative and positive, or at least given some the results section is purely to say this is what we found. When we looked at this and this happened. It's not to say, not explaining why or how or what the scientific explanation is. That is all for the discussion. The results section should purely be descriptive of the results that have been identified in the study. Okay, so then after the results section, then you move on to the discussion. Now, we said the introduction was subjective. The discussion is also a subjective section. Okay, so the authors are taking the results that they found and step by step are explaining why those results are as they are, how it ties in with the scientific literature that is already out there on that topic. They're trying to find plausible biological reasoning behind those results, making sure that they make sense essentially. But there is an element of subjectivity to that, because what you find in science is two scientists from slightly different backgrounds could read the same paper and come up for different reasons why the results were as they were. And that's because of expertise and what you're familiar with in the literature base, the research field. And that's why we have letters to the editor, which is where other scientists can comment on your work and say, well, you said A and B were linked like that because of this, but I think it's actually because of this. And that is discussion, isn't it? That's what scientists do. That's how we understand it from all angles. So again, it's a subjective section, but there needs to be reasonable, plausible reasons behind the results that they found in relation to the scientific literature. Okay, that's the first thing. And then the second thing is how the results of the study published that has been done compares to other results in other studies from the literature. Are they the same? Why are they the same? Were the methods the same? Were the population the same, etc.? Were they different? More interestingly, why could they be different? Was it because the methodology was different? Was it because the population were different? What was it that made it different? And it's not uncommon to have a research question that is investigated multiple times with very subtly different methodologies, resulting in some results that are positive, some that are negative. And that's where, in this discussion section, you need to bring all of that together and make sense of the literature. Why in your study you have shown this, and that it's positive, for example, and not negative compared to the other studies. So that's another important part of the discussion. And then the final important part of the discussion is the limitations. Okay, so all science should be good science. It should be done to the best within our constraints, within the finance available, within what's feasible within your scientific setting. But there will always be things you could improve on. So if you could have had another 100 patients, or if you could have had a better randomization process, or whatever it would be, you need to put that you need to be clear about it and put it in the discussion. You need to say, yes, these are results, however, these are our limitations. And then it's for other scientists to decide if those limitations are significant enough to have affected the results that they are presenting. And again, that is slightly subjective measure, but sample size is a very common limitation. Length of study, so study duration is another common one. And then, methodology, if it's purely a cohort study, it's never ever going to be as good as a randomized controlled trial, but it's still giving you information that helps us, weigh up the database essentially. So that, and then after the discussion section, you usually have a concluding section, which is where there's no new information presented. They're purely saying a summary of the results that they found, and a key finding, a key take-home message, why they have found those results, how that's applicable to clinical practice. Going back a bit into the discussion section, also sometimes some authors put in areas for further work as well, which is quite nice, particularly if you plan to do that further work. But it might be other groups are doing that work or wanting to build on it, and then you're adding it all up to get a better idea. Now, so what I would say is, when you're critically appraising scientific articles, you should be critical. It's good to be critical, but remember to I think it's good to be positive about everything that's published. There is good and bad in everything. If you're going to rule something out completely, you're going to say it's not good enough. You need to have good reasoning why, because there are always limitations. Even the best randomized controlled trials in the world have limitations to them. So you shouldn't be overly critical, but you should just be thinking like a scientist, is what I would say when you're looking at a paper. And do you believe it? Is it believable to you as a scientist? If so, why? If not, why not? And justifying it all the way along, which is very important as a doctor. You have to justify everything you do as you go along, the risks, the benefits, etc. So it's about having that balanced opinion about a paper. And sometimes, with when we're talking about the quality of research studies, if it's a very niche area, you're never going to have a randomized controlled trial in it, because it's right at the start of its literature journey. There might only be a handful of articles that publish about it already, and you need to start somewhere and then start to build up your database, build up the quality of the studies done to build up your understanding about the topic area. So yeah, I would say keep reading, keep critically appraising. You will get better as you go along. If you want to use a helpful tool, a tool that I know of that I've used is called the CASP tool, CASP, which has a whole range of different article styles that you can appraise, that you can practice with. But what I would say is it will definitely come with time, and it will come with practice as a medical student. So don't worry about it. Now, I'm very conscious of taking up a lot of your time. I really hope it was useful. By all means, go back and have a look at this talk, look at the bits that interest you. I'm glad I managed to show you some slides this time. And so that completes my session for this study guide seminar. And then the next one, we don't have a final date yet, but it will be held at the end of March. So thank you very much for your time. I wish you all a very good evening and a restful evening, and I will see you next time. Thank you very much. Take care. Bye-bye.